Thank you. I thought it would be longer than that, so no, I'm kidding. Good morning. It's a pleasure to be here. It's always a pleasure to come to Canada. I was traveling in Canada in the East in May of this year, and always a pleasure to be back here, especially with what happens on the other side of the border. It looks safe and pleasant here, so thanks for being good with foreigners. Nagla reminded me actually that I was invited to the first of these meetings in 2012, and I remember at the time we were discussing how bad telaprevir and boceprevir were for the patients, and hoping that there would be new treatment that would be safer and more efficient, and things have gone so fast, and I think at the time we were not expecting so many patients would be cured, and I had the difficult task today to speak about difficult to cure patients. And there are not that many left. Most patients are very easy to cure, so I see my talks shrinking year after year, and one day you will not invite me anymore because everybody will be cured. So this is my conflict of interest disclosure, and to start, I'd like to remind you what SVR is, a sustained virological response. To achieve an SVR, you have to block viral replication by using direct-acting antiviral drugs that block a step or several steps of the HV life cycle. This blocking is obviously related to the potency of the drugs you use and the potency of the drug combinations you use with additive or ideally synergistic effect. The second condition is to avoid resistance, is to avoid any viral breakthrough, and no resistance means that you have to use drug combinations that achieve a high barrier to resistance collectively. And if you can achieve potency and no resistance, then there will be a second slope of viral decline that will start immediately. The second slope of viral decline corresponds to the cure of infected cells. The cells are progressively cured from the remaining non-replicating HV RNAs, and if you treat patients for a sufficient amount of time, at the end you will be able to cure infection definitively. All cells will get rid of the virus, and the patient will never ever relapse. And this is what we are currently achieving with most of our patients. There are factors that influence the lost cure of infected cells, which is a key element of the cure. Some of these factors cannot be modified. This includes the host genetics. We know that patients who are IL-28BCC have a more rapid second slope of viral decline. Disease characteristics can also influence the second slope of viral decline. That's the case of extensive fibrosis, cirrhosis. Cirrhotic patients have a slower second phase of viral decline. They are therefore more difficult to cure. And the HEV genotype is also influencing the second slope of viral decline, and we know that some genotypes are more difficult to cure than other genotypes. There are, however, factors that can be modified, and this is what we play with when we try to reinforce therapy in difficult to cure patients. They include the effectiveness of the antiviral treatment, which is a first phase decline, the type of drugs you're using, the type of combination, the number of DAAs you're putting in the combination. Ribavirin is extremely helpful because ribavirin accelerates the second phase of viral decline through unknown mechanisms. And treatment duration may be a way by which you give more time to a slow slope of viral decline to cure infection during the duration of your therapy. So today I have decided to review with you three groups of difficult to cure patients. The remaining groups of difficult to cure patients, I would say more difficult to cure patients because we still cure majority of them. Patients with genotype 3 infection, patients with advanced liver disease, and patients with HIV resistance. Obviously these groups overlap. If you're a patient with genotype 3 advanced disease with a lot of resistance-associated substitutions, you are a very difficult to cure patient, but schematically I'll split these groups into three distinct ones. So let's start with genotype 3 patients. That's more or less what we think exists, happens in patients who are treated with a biphasic decline of viral replication, and as I told you, the second slope of viral decline, which is dependent on the HEV genotype. There is indirect evidence to think that the most rapid second phase decline is with genotype 2, followed by genotype 1b, and that genotype 3 has the slowest one, and this probably explains that genotype 3 is overall, with the drugs we have, more difficult to cure through a mechanism that remain to be unraveled. And we also know that if you add ribavirin to any of these groups of patients, you will accelerate the second slope of viral decline, and you can therefore compensate the negative effect of the genotype or any other factor on the likelihood of a sustained virological response with a given treatment duration. So how does this translate into a clinical trial? These are results with two pan-genotypic drugs, the sofosbuvir, the nucleotide analog, and the daclatazvir, the NS5A inhibitor. Both drugs are active against all genotypes in vitro, including genotype 3. This is without ribavirin, and as you can see, non-cirrhotic patients achieve very high SVR rates with this regimen. But if you look at cirrhotic patients, including treatment-naive or treatment experienced in red, this regimen is not strong enough to achieve high SVR rates. One option is to add a ribavirin. This is what was done in the ALIGH 3+ study, which is a phase 3b study in genotype 3 patients, F3, F4. For F3 patients, adding ribavirin to sofosbuvir and daclatazvir was enough. You can see here that all patients treated 12 or 16 weeks achieved a sustained virological response. For patients with cirrhosis, 12 weeks of this regimen and 16 weeks of this regimen were suboptimal with SVR rates of 83 and 89% respectively. So for that reason, this genotype remains more difficult to cure even if you use sofosbuvir plus daclatazvir, two potent direct-acting antiviral drugs with ribavirin. It is even worse if you look at the real-life data, and here this is a group of patients with genotype 3 decompensated cirrhosis from the UK early access program, where you see that in the real world and in patients with advanced liver disease, sofosbuvir daclatazvir yielded a 60% SVR rate, and sofosbuvir daclatazvir ribavirin 12 weeks yielded a 71% SVR rate. This means that 1/3 of patients with genotype 3 infection and with decompensated cirrhosis will fail to achieve SVR, will select resistant viruses, and we'll come back on this in the future, will be very difficult to retreat, although they have a very advanced liver disease. So what about the more recent drug that have been approved? Sofosbuvir and velpatasvir is a second-generation combination, one pill, fixed dose duration. Sofosbuvir, the nucleotide analog. Velpatasvir is claimed to be a second-generation NS5A inhibitor. I would say generation 1.5. It's been improved, but it's not as improved as more recent drugs. And you can see here in red that sofosbuvir velpatasvir 12 weeks did better than sofosbuvir ribavirin 24 weeks in green. That's okay, but if you look at the red bars, you see that non-cirrhotic treatment-naive patients achieved a very high SVR rate of 98%, but these SVR rates start diminishing with cirrhotic patients, 93%, and if you look at treatment experience, it's 91% for the non-cirrhotics and 89% for the cirrhotics. Genotype 3 remains a more difficult to cure genotype with sofosbuvir and velpatasvir, and this led EASL to recommend using ribavirin systematically in all cirrhotic patients and in all treatment-experienced patients to improve the SVR rates in these patients. If we now focus on patients who have even more advanced disease, a combination of genotype 3 and advanced liver disease, you can see here the genotype 3 patients. And the genotype 3 patient with sofosbuvir velpatasvir 12 weeks only achieved SVR in 50% of cases. It was 50% of cases with 24 weeks of same treatment without ribavirin, and only the addition of ribavirin was able to increase this SVR rate up to 85%. But again, 85% is suboptimal. It's far from the 95, 96, 97% we're used to get with other groups of patients. So what is coming next, and will we be able to solve this issue of difficult-to-cure patients with genotype 3 infection? In the next year or so, we will have two new combinations approved for use in North America and in Europe. The first one is a triple combination of sofosbuvir, velpatasvir, and a second-generation protease inhibitor called voxilaprevir. This is a triplet regimen. The second one is a doublet regimen with two drugs, glecaprevir, which is a second-generation protease inhibitor, and pibrentasvir, which is a second-generation NS5A inhibitor. And both have high barrier to resistance, and we'll see some preliminary data generated with these drugs, with this drug combination. This is the Polaris-2 study that was shown at the AASLD meeting last year. Sofosbuvir, velpatasvir plus voxilaprevir in patients infected with different genotypes. 8 weeks, you can see here that the SVR rate for genotype 3 patient in this study was 99% versus 97% for sofosbuvir, velpatasvir 12 weeks. So apparently, this combination will yield very high SVR rates in genotype 3 patients. And this is the other study with glecaprevir and pibrentasvir, the other combination, phase 2 trial, treatment naive and treatment experience with or without cirrhosis. No cirrhosis, treatment experience 12 weeks, 2 relapses, treatment experience 16 weeks, just 1 relapse, treatment naive cirrhotics 12 weeks, no relapse, and 1 relapse and 1 breakthrough in patients who were treatment experienced and were treated 16 weeks. Again, this is very promising, and we're much closer to what has been seen with other genotypes. We're not at 100%, but it's never possible to cure everybody. You always have a couple of patients who fail, but this is reasonable, and I think we can conclude on this first group of difficult to cure patients that genotype 3 used to be the most difficult to cure genotype with interferon-free DA-based therapies, but very high SVR rates will likely be achieved with next generation interferon-free regimens, and very few patients with genotype 3 infection should remain incurable in the future. Second important group is a group of patients with advanced liver disease. I think in my professional life, the most striking data I've seen ever is the results of the SOLAR-1 and SOLAR-2 trials that were presented a few years ago. Remember that a few years ago, we had no treatment at all for patients with decompensated cirrhosis due to hepatitis C virus. Interferon was contraindicated. We had nothing to offer. And we saw these results with high SVR rates with a combination of sofosbuvir and ledupisvir was below what was seen with patients without advanced liver disease, but still very spectacular, something like 85 to 90% SVR rate. And this is summarized here for SOLAR-1 and SOLAR-2 in green, and compared with the UK early access program in the real world, showing also excellent results in the real world with this combination of sofosbuvir and ledupisvir in the order of 90%. Now the question is, if you cure HCV in these patients, do you improve the patient's disease? Do you improve quality of life? Do you improve survival? And here the results are less optimistic. This is the same comparison, but this time it's not SVR rates. It's rates of MELD improvement over 3 points. And as you can see, the proportion of patients who improve their MELD score above 3 points in these trials, SOLAR-1 and 2, was approximately 30%, and it was even lower than that in the real life. And therefore, the question is as to it is really useful and important to treat patients before liver transplantation, or to decide to transplant first and treat them afterwards. There were other studies that were also showing that the only patients who benefit from an SVR when they have decompensated cirrhosis before liver transplantation are the patients with less severe liver disease. You see here the difference between patients who have a MELD score below 15 and those above 15 on the left, and on the right, the difference according to the Child-Pugh score. Patients with Child-Pugh A and Child-Pugh B benefit from an SVR, but patients with Child-Pugh C do not benefit much from the SVR. And if you even look at the number of patients who could be delisted from transplantation, that was our hope. We were hoping that we would be able to delist a large number of patients, avoid liver transplantation, improve liver disease, and make them feel better. This is a summary of 3 different cohort studies. The first one is a French study, the second one is a European study, ELITA, and the Spanish cohort is shown on the right. And if you look at the proportion of patients who were delisted after successful treatment in these 3 studies, it was 18% in the French cohort, 20% in the ELITA cohort, and 16% in the Spanish cohort. Delisting is not a frequent event. And for all these reasons, we had a very long, in-depth discussion at the EASL panel, which is writing our guidelines. And the last update of the guideline that was presented in September 2016 says the following: patients with decompensated cirrhosis without HCC awaiting liver transplantation who have a MELD score less than 18 to 20 can be treated prior to liver transplantation. In that group of patients, we expect a benefit for the patients. But in contrast, patients with decompensated cirrhosis without HCC awaiting liver transplantation with a MELD score above 18 to 20 should be transplanted first without antiviral treatment. HCV infection should be treated after liver transplantation, with just a small reservation of this. The latter patients can be treated before transplantation if the waiting time of the transplant exceeds 6 months, and this depends on the local situation. We didn't have much data to support this statement, and especially the threshold. It was a long discussion. As you can see, we could not decide ourselves on 18 or 20, so we said 18 to 20, and this is obviously subjected to the individual evaluation of the patient. But there was a very interesting presentation at the AASLD meeting, which I think validates our choice. This is a work presented by Chatwal, showing the number of patients in which life expectancy was improved. On the left, according to the MEL score, prior to liver transplantation, where the patients were treated prior to liver transplantation, and the quality of life is assessed on the right as well. And as you can see here, the improvement in life expectancy is really substantial below 18 to 20, as we said, becomes negligible after that and even inexistent above 25. And the same is for quality of life, where there is a very small improvement in the quality of life in patients with a high MEL score and no improvement at all up there. And I think this clearly validates the threshold we decided to use, especially if you look here, again, the ideal timing for HBV treatment prior to liver transplantation by UNOS region, and you see discrepancies between the regions, which I've hard time understanding, but pretty strong differences, with some regions where the improvement is seen for higher MEL scores, whereas some regions have really no improvement at all around 18, 20. And I think this further justifies the choice we made to recommend treating patients with a high MEL score after liver transplantation. And this is strongly supported by the excellent results of therapy you can get after liver transplantation. This is an integrated analysis, again, of SOLAR-1 and SOLAR-2 studies, but this time in the post-transplant assessment. And as you can see, if you treat patients early enough after liver transplantation, you'll have very high SVR rates, 24 weeks or 12 weeks, F0, F3, Child-Pugh A, Child-Pugh B, very high SVR rates. If you wait for a while, and especially if you wait for the patient to develop more advanced liver disease, the SVR rates will start diminishing, and therefore it is important to treat these patients early after transplantation. So to summarize, patients with decompensated cirrhosis are more difficult to cure than patients with compensated liver disease. SVR is not necessarily associated with substantial clinical benefit in patients with decompensated cirrhosis awaiting liver transplantation, and therefore the transplant first, treat after transplantation is a very reasonable option in patients with a high MEL score above 80 to 20, and I think we now have data that support this statement, and this is what we are currently doing in my place. The last point I wanted to discuss with you is HBV resistance and treatment failure, and the issue of resistant viruses and resistance-associated substitutions. There are several factors that influence HBV resistance to DAAs. One is a genetic barrier to resistance of DAAs, and the reason why we combine different DAAs with different barriers and different targets to increase the global barrier of the combination. But what is also important is the fitness of the resistant viral variants. If the virus is selected, if the virus is highly resistant, but unable to replicate, it will not be a huge problem. And drug exposure is important. If you increase drug exposure in such a way that you retain some effectiveness against the resistant virus, you'll be able to get rid of these viruses as well. And this is the interplay that you have to deal with to try to get rid of all the viruses, including the resistant viruses, and not only the sensitive ones. So you know that HBV DAs split into two subgroups. 3 classes of drugs have a low barrier to resistance. They include the NS5A inhibitors, the NS3 protease inhibitors, and the non-nucleoside RNA polymerase inhibitors. And one group has a high barrier to resistance, the nucleotide analog RNA polymerase inhibitors. This slide is a very schematic representation of what happens in a patient who is infected at the start of therapy with a quasi-species, which is a combination, a mixture of different viral populations. I've shown you initially the biphasic decline of viral replication. It was very schematic, very simplified. This is oversimplified too, but a little bit less simple, and will help you understand what happens. In fact, at the beginning, the patients are infected with different populations. The sensitive population, which is generally the major population, has a very rapid first phase decline because the drugs work very well on this virus, followed by a second phase decline, and this sensitive viral population is eliminated during the course of treatment very rapidly. You generally have resistant viral variants that have moderately reduced susceptibility, generally present as minor population. The effectiveness of the drug on these populations is less than the sensitive virus, but still this can be reduced. They can start a relatively slow second phase decline, and if they are treated for long enough, at the end they will be able to be cleared by therapy. And finally, you have highly resistant viruses, generally less fit, present as very minor populations, undetectable in the vast majority of cases. These ones have no effect at all, of literally no effect of the DAAs. They will have a flat curve on treatment. At the end of treatment, they may remain at the only one that still survive and replicate, and then they will be able to acquire fitness by accumulating fitness substitutions and be responsible for the relapse. That's what happens in patients who fail to eradicate HCV on DAA therapies, and this explains that the vast majority of patients post-treatment failure have dominant resistant viruses. So how does this happen? Yes, I'm almost finished. But I'm French, so to get me out of here, you need first a revolution, secondly, cut my head. It's difficult. Anyway. So let's go back to resistance. Resistance is also a French specialty, French resistance, remember. So anyway, this slide shows you the influence of the pre-existence of resistance-associated substitution, resistant viruses detectable at treatment baseline on the SVR. And this is with the combination of sofosbuvir and ledipasvir, guidelines recommended treatment. Patients with detectable NS5A RASes are in red. The ones without NS5A RASes are in green. And as you can see, the SVR rates were always lower in the presence of NS5A RASes, especially if it was ledipasvir-specific RASes conferring high-level resistance than in those without NS5A RASes. The same is very true if you look at another treatment regimen, grazoprevir-elbasvir, where the presence of RASes had a very strong influence on the response. 12 weeks without ribavirin, elbasvir class RASes, 29% SVR rate compared to 97% without NS5A RASes. If you add ribavirin and increase treatment duration, everybody responds. This is true for GTAP1A, this is true for GTAP1B, and it's true as well for patients in sofosbuvir, hepatitis treated 12 weeks with decompensated cirrhosis, 80% SVR rate with NS5A RASes, no NS5A RASes, 96% SVR rate. And you can see here that if you add ribavirin, you remove this effect of NS5A RASes, and everybody achieves a cure of infection. So there is an influence, but it's possible to prevent this influence by adding ribavirin. When failure occurs, what happens? Well, two things. If you've been treated with a protease inhibitor, the protease inhibitor-resistant viruses will progressively disappear. These are patients who have received grazoprevir and elbasvir. And as you can see, the protease inhibitor-resistant viruses progressively disappear. And after a few weeks to months, nobody has any NS3 protease inhibitor resistance associated substitutions. In contrast, the NS5A resistant viruses remain, and these NS5A resistant viruses will remain forever. And this will have a major impact on retreatment. If you consider that every single treatment regimen right now has an NS5A inhibitor, it means that all patients who fail on treatment right now, all patients who do not achieve an SVR, will have NS5A resistant viruses after the end of treatment, and they will become extremely difficult to retreat. So how should we retreat these difficult to retreat patients, the ones who have been exposed to NS5A inhibitor containing regimens? Well, based on these all recommendations, the retreatment regimen should contain sofosbuvir, 2 to 3 other DAs, if possible, with no cross-resistance with the ones already administered, plus ribavirin. This is very heavy treatment. Most of it is off-label, but this is how we retreat our patients because there is no other option. Treatment duration should be 12 or 24 weeks, and close monitoring is required for the reasons I said. These are off-label combinations, and very limited safety data is available for these patients. So for GTAP1 and 4, we have a lot of options. Sofosbuvir plus bemnifosbuvir, paclitaprevir, desabuvir, ribavirin. It's 6 drugs together. It's a very heavy regimen, but it works. Sofosbuvir, grazoprevir, elbasvir, or sofosbuvir, declatesvir, cimeprevir. For GTAPs 2, 3, 5, and 6, we don't have many options. Only sofosbuvir, hepatitis, but there is an alternative to it, which is to wait until new therapeutic options become available. I would like to briefly, before they cut my head, briefly show you a few examples of retreatment strategies with these different regimens. This is a Quartz-1 study, a retreatment study with genotype-1 patients, 12 weeks. As you can see, sofosbuvir plus 3D and DA failure was efficient. 93% in genotype-1A no cirrhosis, 100% in 1A cirrhosis, 1B 100%. Small number of patients. Limited efficacy data, limited safety data, but we are using it and it works. The other study is a study we presented at the ACLD meeting showing a 100% SVR rate when you retreat NS5A exposed patients with sofosbuvir plus grazoprevir/elbesvir. It's a good retreatment with ribavirin, and the treatment was very well tolerated. If now you use the new strategies, voxilaprevir, velpatasvir, you see that there are many specific RASes that can be selected by these drugs in vitro. But let's have a look at the in vivo situation. The in vivo situations show that if you have no detectable RASes and you treat patients with sofosbuvir, velpatasvir, voxilaprevir 12 weeks, the SVR rate will be 100% in blue. If you have RASes that confer resistance to any of these drugs and you treat them with a combination, the SVR rate will be 98%. The combination altogether has a very high barrier to resistance, and this translates into the two retreatment studies that were shown at the ACLD meeting. Polaris-1 with sofosbuvir, velpatasvir, voxilaprevir in genotype 1 to 6 NS5A experienced patients, 96% cure rate, and in DA experienced NS5A naive, 97% SVR rate for genotype 1 to 4 in Polaris-4. So excellent results in terms of retreatment with this triplet combination. The other combination I mentioned is glecaprevir/pibrentasvir. I like this slide because it summarizes all the in vitro data we have showing the level of resistance conferred by the different amino acid substitutions, which are shown at the bottom here. And here you can see at the front, glecaprevir, and behind it, cimeprevir in orange, boceprevir in blue, and telaprevir in red. And on the right, grazoprevir and paritaprevir. And to make it short, you can see that the resistance profile of glecaprevir is better than that of any of the other drugs, except for one substitutions at position A156. However, we know that although this substitution confers high-level resistance, it also confers poor fitness. These viruses do not replicate well, and for that reason, they are not clinically significant. They can be selected, but the virus will disappear very quickly. Very good drug. And now this slide shows you pibrentasvir, second-generation NS5A inhibitor. The comparison with the other drugs is even better. You see pibrentasvir at the front and the other known drugs at the bottom. Very high bars for the other drugs, very low bars for pibrentasvir. This combination is very promising, very efficient with a high barrier to resistance with only two drugs. And this translates into retreatment strategies. The Magellan-1 study showed 100% SVR rate, one relapse in the second group, and one breakthrough in the third group with different combinations of glecaprevir and pibrentasvir in retreating patients who had been exposed to NS5A inhibitors. A very promising combination. And finally, to please the third sponsor, there has been also another study, more preliminary data. This combination will not be available this year, but probably next year. This is a triple combination of a nucleotide analog, MK3682, with grazoprevir and a second-generation NS5A inhibitor, ruzasvir. And again, very high SVR rates can be achieved in patients who had been exposed to NS5A inhibitors. 98% with ribavirin 16 weeks, 100% without ribavirin 24 weeks. You see that there is hope for retreatment of these difficult-to-cure patients in the future with the new combinations. So in conclusion, and this will be the final one, patients never exposed to NS5A inhibitors are relatively easy to retreat with current DA combinations, provided that DAs without cross-resistance with the drugs already administered are used. NS5A inhibitor-exposed patients, in contrast, are difficult to retreat. They require the combination of sofosbuvir plus 2 or 3 other DAs, plus ribavirin for 12 to 24 weeks, and very close monitoring. They may require to wait until alternative therapeutic options become available. You've seen that these options will be available in 2017, and they are extremely promising. So I hope that we will further increase the results of our therapies and achieve very high SVR rates anyway, with very few patients who remain incurable. On this, I thank you very much for your attention.
Thank you. We have time for a couple of quick questions. Can I ask ask just real quickly, when you use that MELD cutoff, was that natural MELD, or that wasn't like with MELD exception points, for example, if we have someone with HCC?
It was a natural MELD in that, yeah. I think it's still debatable, and we had to, we wanted to be clear and precise and take a risk of recommending something which is subject to debate. I was very happy to see the data presented by Chatwal at ASLD, but if you look at the data, literally you could move the MELD score a little bit to the right and you would probably still be correct. I think a very important parameter also is the time needed to get a transplant in your place. And this plays a role, and if you have to wait for too long, you will have to treat patients anyway.
Good morning. My name is Sandy Léo-Laframboise. I don't really have a question, but what I really would like to do and offer to all of us is an acknowledgement that we are on the Treaty 7 area and the Stoney People's land, and there's 8 nations in this area. And in the theme of truth and reconciliation, I think it's important that we acknowledge my people in this way. So I acknowledge that we are on these traditional territories as an elder. So thank you.
Thank you.
Greg Dawes, Sydney. Jean-Michel, with the additional data from Polaris 3 on the genotype 3 cirrhosis population with SOF or Hepatitis in the 95% SVR rate, do you think your guidelines will change at all, or will you still be recommending the addition of ribavirin to that regimen? Or should we be doing resistance testing pre-treatment, adding ribavirin for those with RAS?
So I think our position and my position on resistant testing is that if you have it available and you trust the assay and it's easy to do and does not limit your ability to treat patients, you should do it and give ribavirin only to those patients who have the Y93H. This is a case in my place, it's probably the case in your place, but there are many people who do not have access to reliable resistant testing. So if you don't have access to resistant testing, you should not prevent yourself from treating. You should not limit access to care, and therefore you can treat patients with ribavirin, and in that case, you will treat all cirrhotic patients and all non-responders. The question is, will we still need to use ribavirin? I think the choice will be between Sub-Vel ribavirin or the new combinations. The new combinations have no ribavirin, but they have 3 drugs, and I think we will have in the real world to check whether Sub-Vel ribavirin is not better than Sub-Vel Vox or glecaprevir pibrentasvir. If this is the case, everybody knows I like ribavirin, but I don't love it by nature. I like it because it's useful. If it becomes useless, we'll be happy not to use it anymore. But ribavirin is interesting for other viral infections, I think, other RNA viruses. So we'll be back with ribavirin at some point.
So thank you very much for a clear and concise talk.